Good afternoon, and thank you. I want to thank the Brazilian Orthopedic Congress and Dr. Estevez for inviting me out here to speak today. I'm going to talk to you a little bit about a topic that you may or may not always think about, and that is atypical femur fractures and their relationship to bisphosphonate use. This is becoming an increasing problem everywhere with osteoporosis treatment, and I suspect in Brazil it's no different. What I'm going to cover over the next 15 minutes, we'll talk a little bit about the definition, we'll cover the incidence, some of the indications for surgery, maybe what they should be or shouldn't be. We're going to look at the risk benefits of treating osteoporosis with these pharmacological drugs. And then finally, we're going to look at the fracture themselves and is the healing the same or different, and what we expect our patients if we have to manage these problems. So keep this case in mind as we go through the talk today. This is a 63-year-old that had a 6-year history of bisphosphonate use, and this is pretty typical. We see a subtroch fracture, and I'll go over the appearance of that fracture and what makes it classic for a bisphosphonate type stress fracture. And of course we know it's pretty common sense. We're going to fix this. We're going to fix it with an intramedullary nail. But the real question is what to do for the other side, right? So do we image it? How aggressive do we need to be about imaging it? And do we need to fix it if there's something there? So this process and this problem really was very difficult to start to recognize. I think we started seeing a little bit of this in the late 1990s, early 2000s, but it really wasn't until about 2008 where this American Society for Bone and Mineral Research finally decided to come out and take a stand and say, yes, bisphosphonates do have a relationship with these atypical fractures that we're seeing. So here's an example, at least on my left, your left as well, and on the right, we have a more typical and an atypical fracture. And clearly that pattern of the atypical fracture is that transverse lateral fracture line with the small, usually medial wedge, and you'll see that cortical thickening laterally, and occasionally you'll see some cortical beaking. It's much different than the typical fracture we see from a fall where it's a spiral or a higher energy where there's some comminution. So the vast majority of patients that have radiographic changes probably go unrecognized, and when we do recognize them, a lot of them don't necessarily need to have surgery. Here's an example of just some lateral cortical thickening that we see. When we see this, we probably have some concern, and we may think about what we want to do to manage the patient medically, but in general, this is one that doesn't usually go on to fracture. Here's another example. Very subtle lateral cortical thickening, not really beaking, and again, this one we probably could consider watching. But when we see something more like this, and I don't know how well it projects on your screen, there's actually a little what we call dreaded black line, and you can see laterally where there's a little bit of a beak, there's actually a subtle fracture line starting to exit the lateral cortex. And if we look at some of the papers that are out there, when you start seeing this dreaded black line, better than 90% of these are going to end up fracturing. So better than 90% are going to end up fracturing. If you see this, I think you definitely should consider operating on them. If they don't have it, the risk for fracture goes down fairly dramatically. Here's just another example. It can be very subtle. You see actually two of these dreaded black lines. They are sort of incomplete fractures essentially. This one is clearly and very obvious, and I think we would all agree we'd consider fixing that. And here's another one where it looks like it's almost partially healed. Patient with thigh pain, and you get a radiograph that looks like this. I would think most of us would agree to fix. An area where it gets a little bit tougher sometimes is we also see these patients, they have an excessive lateral bow, and it's been written up a little bit, and sometimes they're difficult to rod. I'm not going to talk so much about the techniques of dealing with rodding for these, but what's important to know is when you start seeing these lateral bows, they have a lot of tension on the lateral cortex, and these are set up for fracture, so tend to be very, very much more aggressive with these lateral bowing of these fractures. So how often does this occur? Well, we're seeing it more and more, and when you see 2 or 3 in your office, you feel like it occurs a ton, but the truth of the matter is it's still pretty rare. It's still only anywhere from about 0.5% to 4%. We do know that if they're on a bisphosphonate, the longer they're on, the more likely they are to have this potential problem, and when they come off the bisphosphonate, their risk drops fairly dramatically. And what about the other side? So if a patient has a fracture or doesn't have a fracture, if you just routinely imaged 100 people asymptomatic on bisphosphonates, usually about 1 to 2% are going to have some change. The question is what to do with that, and I'm not sure I'm going to be able to give you the perfect answer, but I'm going to tell you a little bit about what the literature says and then a little bit about what my opinion is. So here's another example of I think a 72-year-old that had this change that you can see on the right side. She has definite lateral cortical beaking in the subtroch region, and she had no pain. We elected to watch, and we continued to watch, and roughly 11 months later, she developed a similar finding on the contralateral side. And she was asymptomatic on the right, but on the left she started having a little bit of pain. She didn't want to have surgery. She was pretty successful having no surgery on the opposite side, and then 2 months later she came back and fractured on the left side, not the right. So the right side was there for 17 months with no problem. So it's very hard sometimes to tell which ones are going to fracture, and it gets treated with a cephalomedullary nail. So what about the incidence of bilaterality? So that was an example. We saw it on one side, eventually it developed on the other. The literature is widely variable. I would say in my practice probably close to a third, maybe a little bit more, actually have changes on another side. So for me, if I fix one that has a stress fracture on the right, I'm going to get an x-ray on the left while they're in the hospital just to be sure. So what patients are at risk? Are they all patients? Well, we know if they're on bisphosphonates, usually 3 to 5 years, they're definitely at risk. But there's also an interesting twist with bisphosphonate fractures. They tend to occur in our younger age patients, the ones that tend to be more active, they're stressing their bones more, that tend to have micro cracks that aren't getting remodeled because of the bisphosphonates. It's also a little bit more risky when they have pain, but as I showed, and as I'll point out again in this next slide, really about 30 to 50% never have pain and they end up breaking. So pain isn't guaranteeing you that there is a problem or not a problem, so keep that in mind. So ultimately, if we look at all the variables that tell us which patients are at risk, if they're on a bisphosphonate and they've been on it for 3 to 5 years, they're younger age group, usually fair-skinned Asians at higher risk. It's mostly our female population. They're osteopenic or osteoporotic, and then oftentimes if they do have pain, I certainly have a heightened awareness of this problem. So all those can certainly play a role in your decision making on how aggressive you want to be, especially on working up a patient on the contralateral side. So as I said, for me, if they fix a fracture on one side, the other side automatically gets an x-ray. It's pretty low cost, and I think it's easy to do. The really hard part comes into play is if they have a change and they're asymptomatic or they're not symptomatic, and what to do after that. So for me, if they're symptomatic and they have a radiographic change and they've already fractured on one side, it's pretty hard to talk the patient out of surgery, including me, trying to talk me out of it, and usually we will end up going on and fixing those patients. If they have no pain, they're asymptomatic, then it gets a little bit more difficult. There's been some work looking at bone scans. I personally don't think they're a big help relative to the cost. You can also get an MRI, and there's been several papers looking at the ability of an MRI to delineate a fracture that maybe goes all the way across. Again, it's more expensive. I don't think it really separates the decision making. I think it's more about your relationship with your patient and you and your patient making that decision and deciding, do I want to have it fixed or not? How comfortable am I taking a risk of not having it fixed, knowing that it could break? So getting back to that patient that was 63 that had a bisphosphonate fracture on the left side or right side, here's her radiographs on the left, and you can clearly see there is some change in sort of the just distal to the subtroch, maybe almost the mid-shaft region. You see cortical beaking, you see a little bit of reaction within the endosteal canal, so certainly some concern. And the question is what do you do now? Well, if we look at the literature, and there's been a couple papers, one in 2011 in JBJS, trying to address this exact question. And the recommendations are really weak, and I'm not going to read what's on there, but the bottom line is we really don't know. Their recommendation was if there's pain, to get a bone scan or an MRI. For me, if there's pain, I'm going to fix it. So don't really prescribe to their recommendation in that regard. If they don't have pain and I have a discussion with my patient and they're interested in just watching it, I'll usually wait about 6 to 12 weeks, and when they come back for radiographs of the side I fixed, we'll re-x-ray that side. If they have any symptoms or any changes radiographically, I'm going to fix them. The article recommended an MRI until it's, quote, normal. I don't think serial MRIs are justified from a cost standpoint, nor do I think they're going to help you at all make that decision. What about medically? What do we do? So we have a patient, they've been on bisphosphonates for 3 to 5 years, and they end up with a fracture. First thing, stop the bisphosphonate. The half-life is almost 8 years, so a long time. That's going to stay in their system and in their bone, so you don't need to keep them on a bisphosphonate. We personally start them on a teriparatide, PTH, for 2 years after. I think it helps the healing, which, as I'm going to get to in a few minutes, is a problem. But keep that in mind. It's certainly not standard of care, but I think it can make a difference. And then we, of course, check vitamin D. 80% of our population in the United States is low in vitamin D. Actually, in Brazil, 60% of the population is low in vitamin D, even with sun exposure year-round. So I think vitamin D and calcium are good regardless. And ultimately, it's always about cost, and this is a discussion I guess you have with your patient, but I sort of follow the outline that I just laid out regardless. And the last point I really want to make about these fractures relative to the typical fracture is that their healing is a little different. It's definitely slower, and when you look in the literature, there's several papers that show delay in healing and even non-union rates tend to be higher. So keep that in mind, especially when you try to take this data and you're looking at a patient, not the one that necessarily is broken, but the one that you're thinking about might break and you're concerned with it. There's a big difference. If you fix it before it breaks, like this one, you don't have to worry about 9 months, 11 months of healing, and constantly seeing that patient, explaining to them that the bone isn't going to heal the same process as a normal fracture. So what did we do with our 63-year-old with the 6-year history of a bisphosphonate after breaking on the right side? We ended up fixing her on the left, and interestingly, as we were fixing her, it broke. So you can see the fracture line there where it's lateral and it went all the way across through the medial side. So certainly we were happy that we fixed it. It would have been more happy if we fixed it earlier before it ever broke. Then we don't have to worry about the potential in a delayed union. So in summary, when I think of these fractures, remember, it's more of a stress fracture, it's atypical, and there's no question, you can still have a normal stress fracture in patients, but there's clearly a relationship with bisphosphonate use. Remember the x-rays that we looked at and be aware of those changes. I think they're really important both on the fractured side and the non-fractured side. Again, as I said, they're usually been on bisphosphonates for 3 to 5 years, but I've seen it in patients that have only been on for a year. Typically, they're younger and almost always female, and they typically have slightly T-scores that aren't quite put them in the osteoporosis range. They tend to be more osteopenic. And about half to 70% are going to have pain, but remember, not everyone does, and so that's where it really gets difficult. When you see a patient that has a change, doesn't have pain, what are you going to do? Often bilateral, so if one breaks, don't forget, get an x-ray of the other side. It's more common in whites and Asians, and patients that have steroid use makes their bones more brittle, as we know, and they certainly have a higher risk. When it comes to the medication, my recommendation is stopping the bisphosphonate on those patients. These fractures actually still can heal while they're on a bisphosphonate, which is somewhat controversial, but I still think they've been on it for 3 to 5 years. The half-life is 8 years. There's no reason that you should keep them on that bisphosphonate. Definitely remember that healing can be delayed, and that's where something like a teriparatide might help that situation. And so oftentimes we do put our patients on a PTH agent as well. And then finally, don't forget vitamin D and calcium. It's something very easy and simple that you can do. Thank you.